Hi, I welcome you to this new session in which we'll discuss another form of optic neuropathy, which is known as glaucoma. I'm Dr. Rashmi Malhotra, and I'm Assistant Professor in Department of Ophthalmology in DMC Ludhiana. By definition, it is the chronic progressive optic neuropathy characterized by morphological changes at the optic nerve head and retinal nerve fiber layer, leading to characteristic visual field changes in the absence of other ocular diseases, with or without a raised intraocular pressure. Normal intraocular pressure is 10 to 21 millimeter of mercury. It is the second leading cause of blindness in the world and third most common cause of blindness in India. It leads to irreversible vision loss, and more than 50% of patients are unaware of the disease. They are carrying, but they don't know. Hence, it is also known as the silent thief of vision. It is multifactorial in origin, in which elevated intraocular pressure is the most important factor, followed by optic disc cupping. It increases with age, that is, it is more common in 5 to 7 decades of life. It is more common and severe in black population, and family history plays an important role. There is a risk of about 10% in siblings and 4% in offspring. Other causes are diabetes, systemic hypertension, myopia or extreme hypermetropia, thin central corneas, steroid usage, migraine, cigarette smoking, Graves' disease, and caffeine use. Now let's understand the pathophysiology of glaucoma. It can be either because of the excessive production of aqueous humor or the decreased outflow of the aqueous humor, which will lead to increased IOP. Now this causes damage to the retinal layer as it passes through the optic nerve head, along with the compression of the optic nerve head itself, which results in cell injury and death. Now, out of the two mechanisms discussed earlier, the decreased aqueous outflow facility is more common than the increased aqueous production, leading to raised IOP. Now, out of these, there are two theories to axonal loss at the level of optic disc. One is mechanical, in which, due to distortion of lamina cribrosa, there is impaired exoplasmic flow. And there is another theory which is vascular, in which the optic disc ischemia occurs with defective autoregulation of the blood vessels. Now, in mechanical, it is the compression, and in vascular, it is ischemia. Now, coming to classification of glaucoma, which can either based on presentation, that is acquired at the later age, or congenital, which is present at birth. Ocular association, that can be either primary, not associated with any other disease, or secondary, which follows some ocular disease. Then angle, which can be either open or closed, or the course of disease, that is acute or chronic. By now, we have understood that aqueous humor plays an important role in the pathophysiology of glaucoma. So I think we should know something about aqueous humor also, which is produced in the ciliary body band in the posterior chamber of the eye by diffusion, secretion, and ultrafiltration. Out of this, the diffusion and ultrafiltration both are passive mechanisms, whereas secretion is an active process. Now, this is an MCQ question, which is the active process of aqueous humor production, that is secretion. Another MCQ question, the rate of formation of aqueous humor in healthy human eye is 2 to 3 microliter per minute. As compared to plasma, aqueous humor contains more amount of ascorbate, chloride, lactate, and sodium. Now, the functions of aqueous humor, it maintains IOP, which is important for ocular development and maintenance of the global integrity throughout life. It serves avascular structures of the eye like cornea and lens by providing substrates, nutrients, and removing metabolites. It delivers high concentration of ascorbate, which scavenges free radicals and protects against UV rays and other radiations. It produces local paracrine signaling and immune responses. It provides a colorless and transparent medium for eye's optical system. The aqueous humor outflow mainly occurs through anterior chamber angle, mainly through trabecular pathway. Almost 70 to 90% of aqueous drains through this path. Only 10 to 25% drains through uveoscleral pathway. Now this tells us that the angle of anterior chamber is an important part of this disease entity. The anterior chamber angle is the peripheral recess of anterior chamber, which can be clinically visualized by gonioscopy. The following structures can be identified in the normal angle. Starting from posteriorly, it is the root of iris, followed by ciliary body band. Then we have the scleral spur, this white area, followed by this brown layer, which is known as trabecular meshwork. And then the Schwalbe's line. Schwalbe's line is nothing but the ending of the Descemet's membrane. For this angle, we have different grading systems starting from von Harrix, in which we make a very thin slit at the periphery of the cornea, which we compare with the peripheral AC depth. So if the peripheral anterior chamber space is equal to full corneal thickness, it is considered to be a wide open angle. If the space between is 1/4 to 1/2 of the corneal thickness, then it is considered to be grade 3 or incapable of closure. If the space is equal to 1/4 of corneal thickness, then it should be gonioscope. Probably the angle is narrow. So if the space is less than 1/4, consider it to be an occluded angle. But this von Harris grading has a low accuracy in properly identifying the narrow angles. They can be missed. So gonioscopy is considered to be the best method to evaluate anterior chamber angle. Not only that, it can also be used therapeutically for procedures such as laser trabeculoplasty and goniotomy. Then we have Schaeffer angle grading system, in which it depends on the angle width. So angle width, if 45 to 35, it is considered wide open or impossible of closure. If it is 35 or grade 4. If it is 35 to 20 degree, it is considered to be grade 3 or wide open. And below 20, it is considered to be narrow angles. And then we have Spake angle grading system, which is considered to provide more holistic description of the anterior chamber angle, as it also mentions about level of iris insertion, that is anterior to Schwalbe's line, behind the Schwalbe's line, on the scleral spur, behind or on the ciliary body band. Then it also gives the geometric angle, that is the angle width, based on a geometrical angle formed by the intersection of line tangential to the trabecular meshwork with the surface of the iris at the Schwalbe's line. Plus, it also gives the peripheral iris contour. Hence, it also helps us to identify the plateau iris configuration. And the last one is Shy angle grading system, which is basically based on the structures visualized. So, in wide open, all the structures are visible, whereas in grade 1, root of iris is visible, grade 2 up to ciliary body band, the ciliary body band is obscured, rest are visible. In grade 3, posterior trabecular meshwork is obscured, and in grade 4, only Schwalbe's line is visible. If you see carefully, this Shy angle grading system is practically almost opposite to the Shepherd grading system. So based on these grading systems, we can either have an open angle glaucoma, in which the angle is open, or the closed angle glaucoma, where the angle is closed. So in next session, we will discuss about open angle glaucoma. Thank you.